Thank you, Onyinye. Thank you, Brad. Thank you so much. I think we're going to welcome to the high table here to chair the next session on Nigeria in the center page, progress so far, and then eliciting disparities at the state level. This is the data session. And then we'll have two wonderful people who are so knowledgeable in this to chair and co-chair and lead the conversation around it. Presentations will be made by the Track 20 folks. Can I invite Professor Brian Adima? Please, can you come over here? Professor Brian Adima is also a member of the Board of Trustees of AAFP. Please give me a very warm welcome. Professor Ladipo is already connected online. I've just spoken to him, so we're going to bring him in through virtual connection, and he will join us personally later. Over to you, Prof. Thank you.
Thank you very much. Okay, thank you. Thank you very much.
Hello, hello. Hello. The mics are they working? Hello, hello. 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 Hello.
Yeah. Hello.
Okay. Good morning, gentlemen. It's really a great pleasure to share this occasion. It's a very important session because we're going to talk about data. Since the beginning of today, and even the days before, we've listened to a lot of presentations, and we've been fed with a plethora of information related to family planning as concerns our country. It is very, very important. Everyone who is here is showing one commitment or the other towards attaining our desired goal. And I want to commend all of us. And in particular, I want to commend the Association for the Advancement of Family Planning, the technical management team, led by Dr. Ejiko Oji, the Board of Trustees, the chairman is here, Sariki, and every partner that has committed considerably towards what we are doing today. The Federal Ministry of the federal government, the Federal Ministry of Health, has done a lot since the blueprint was developed in 2014, and then the 2020 to 2024 blueprint. I think we're going there. Of course, initially our CPR was targeted at about 36%, but later, in the light of the realities of time, it had to come down. And we have an unflinching optimism that we are going to attain that target. Now, now we are going to look at data. Nigeria is at the center stage. We are going to look at disparities that occur. Do these disparities occur? Inevitably, you know, states vary from place to place. The differences inevitably occur. And there is a lot of difference that you will see between, for instance, states in the south and states in the north, states with humanitarian challenges, states where you have partners aiding, and so on. So I want to call on the moderator to bring in the various presenters to give us this data. You try as much as possible to pick one or two information and ask questions at the end of it. Thank you.
Thank you very much, Professor Adima. The next presentation, which is Nigeria in the Center Stage, Progress So Far, is a draft presentation, and it's be taken by Dr. Adebi Adeshino, who will be connecting from Washington, D.C., and also Dr. Suleiman, who is right here with us. So Dr. Suleiman, please come up to the stage. Thank you very much. I hope Dr. Adebi has connected.
Yes, I have. Thank you very much.
Very much.
Good morning to you all. We stand on existing protocols. This is going to be a joint presentation with Dr. Adebi Adeshino joining from Washington, D.C., and myself, track 20. Dr. Adeshino, please, can you hear us?
Yes, I can hear you well. Can you hear me okay?
Admin, please, can you put up the presentation? Good.
When she started.
Let me know when I can start and I'll get started. Thank you.
Please, you can proceed.
Excellent. Good morning, everyone. It's truly a pleasure to be able to join the 6th National Family Planning Conference. As we all know, it's been a fairly difficult year, but we are grateful to the Federal Ministry of Health, the government of Nigeria, all the partners attending, and everyone who's able to make this happen. I cannot imagine, given the current world that we live in, how difficult it must have been to carry something out of this immense size. I'm deeply grateful for the opportunity to be part of it, and I'm extremely honored at how successful it's been so far, and I look forward to our continued participation in this. It's been a bit difficult for me that since the beginning of the National Family Planning Conference, this is the first time that I won't be able to attend, but I will try my very best to deliver our presentation successfully and to ensure that we are an ongoing conversation regarding how to best support Nigeria's process and monitoring. With that said, I'm just going to dive into our presentation. So next slide, please. So we are going to be looking at Nigeria within the global stage, essentially looking at the global commitment to family planning in relation to Nigeria's commitment to family planning. We're going to talk a little bit about how Track 20 supports the government of Nigeria, and particularly the Federal Ministry of Health and state ministries of health and health apparatuses with scaling up the family planning initiative. And then we're going to go into the actual indicators, the progress indicators, and looking how things have progressed so far in terms of family planning in Nigeria. Once we look at all those issues, all those particular points, then we're going to talk about how, moving forward, how Nigeria can move and address some of the key opportunities that are likely to deliver increased growth in terms of MCPR. My colleague Suleiman Gbadamosi is going to be the one discussing this part. Right. Next slide, please. So let's look at, we're going to talk about the global and national FP commitments. As everyone is aware, at the global stage, partners, governments across multiple countries, donor partners and development partners got together to commit to increasing access to family planning, understanding that family planning access is one of the key, if not the most important, focal point of health development measures across the world. And to that extent, at the global level, there was a commitment to increase the number of additional users of modern contraceptive methods by 120 million by 2020. Nigeria, as we're all aware, is one of the initial commitment partners, and at the time in 2012, committed to reaching a 36% CPR by 2018, and to spend 3 million per year on contraceptive. And then it developed, in terms of putting this into action, Nigeria developed its national FP blueprint and supported its respective states in terms of how they would also develop their measures in terms of expanding access to family planning. In 2017, Nigeria made a renewed commitment to reaching 27% modern contraceptive by 2020, but I believe that's been extended now to 2023. Next slide, please. In terms of our partnership, Track 20 essentially represents the monitoring arm of the FP2020 infrastructure. Our goal has been to continue to provide support to federal and state efforts to collect, analyze, and use data to track FP progress, building capacity with M&E officers and their program counterparts, ensuring that their stakeholder and decision-making bodies have access to information, evidence-based practices to ensure that decisions are well informed. As part of this, we also provide support in building a consensus on FP blueprint, state CIP, and FP 2020 indicators to ensure that there's a uniform and standard way of measuring family planning progress, and ensuring that we are all working towards the same goal. And lastly, but not least, we encourage use of data for FP policy development, resource investment, advocacy, program design, and ultimately implementation of tried and tested family planning measures. So with that said, I'm going to go into the current progress indicators and provide a little bit of analysis. I'm going to try not to overload you with data, but pick a few key things that I think carry a message across about how things are going. So here you see the FP 2020 core progress indicators. There are approximately 17, and an 18th one is currently been added. There are some key, the first 8 progress indicators are essentially looking at both progress and impact. And then the latter indicators are looking at progress from a program perspective. Next. For our discussion, next slide, please. For our discussion, we're going to be focusing on these 2 key progress indicators, looking at the additional number of users and MCPR growth. So before I go into the detail about what what those indicators, what the actual numbers are, I want to first talk about the process about it, and many in the audience currently know what this process is involved and have been part of it from the initiation since we've been working in Nigeria in 2014. So generally, we try to build a data consensus. What does that mean? We want to be able to use global trends, regional data, and country data to determine modern contraceptive prevalence rates. And how do we do that? Next slide. Next. Yes. We want to avoid the confusion of pooling data from different survey sources at the same time, some of which may not be exactly may be equal to each other. We want to avoid the situation where someone comes up and says, I'm going to use NDHS. Another person comes up and says, they're going to use mix. And then a third person comes up and says, no, I'm going to use DHIS2. To avoid that, we've created a process that pulls in data, as you see from the diagram, pulls in data from multiple multiple sources, and then runs the analysis using a statistical model that was based on a United Nations Population Development Model. It's essentially called the Family Planning Estimation Tool, FPET. FPET was developed as a way across that all countries agreed to to be able to pull data from multiple sources, to be able to use data in a way that creates a sort of accurate salad. So if you think about creating a fruit salad, you want to be able to pull your banana, your melon, your grape, and your apple, and so on and so forth. You want to be sure that they complement one another and the taste is actually good. And to that extent, we review and ensure that the data are able to match one another in the sense that we can give them we can give them relative weights and then analyze them in the trend. And with that trend, we're able to develop at least a trend that follows somewhere in the average between all those data points. So when we are talking about, in Nigeria's particular case, when we're talking about pulling together data, we used data that came from the NDHS, from mixed surveys, from LMIS, UNFPA, Health Facility Assessment, the needy expenditure analysis, national group FP briefing, and as well as private sector data. At the global level, we use something very similar, pulling in different data from surveys, from national surveys to DHS and mix. And then we also use their routine service delivery data pulled from each country's HMIS sources, very similar to DHIS2, LMIS, and Navision. Next slide. So when we pull all these data together, in Nigeria's case, when we look at the analysis, we try to compare between what we see in terms of what our goal is, which is the green line, what we intend on achieving by 2023 relative to where we are. So in our current trend, based on all those data points that I discussed earlier, the blue line represents how Nigeria is moving along in terms of family planning. And from what is there, you can see that the data shows that Nigeria is approaching 11.7%, estimated to approach 11.7% MCPR by the end of this year. For the number of additional, can you hold on, please? Thank you very much. So as you can see at the global level, the MCPR is growing from a little bit above 30%, and it's been growing to a little bit above 35% now. And that's been the progress over the last, since the beginning of the initiative in 2012. Next slide. So when we talk about what is the contribution of MCPR growth, what we're looking at is the actual number of additional users. That's the number of people that we started out with in 2012 and number of people that we have in 2020, and how many additional users did we gain between that time. So in 2012, we had 3.3 million people estimated on modern contraceptive prevalence methods. In 2020, we ended up with almost 5.6 million additional, 5.6 million people. That meant that we saw an addition of 2.3 million users, which is the blue square. We saw an addition of 2.3 million users. That meant that we grew by approximately 70% in terms of modern addition, in terms of modern FP users. So it was a fairly substantial growth in terms of additional users. Next slide, please. So when we talk about the actual impact of growing an MCPR, what does that mean? It means that you have approximately 5.6 million women who are using modern method in Nigeria. And that translates to an impact, a substantial impact of almost 2 million unintended pregnancies being prevented. So essentially, we're preventing unintended pregnancies at a very large scale. And that also translates to some major health impact in terms of reducing the number of unsafe abortions, which is reducing by approximately 705,000 unsafe abortions. And the most important and key message of this is that in terms of that, the use of family planning, and particularly modern contraceptive method use, we are able to prevent 13,000 maternal deaths. That is extremely important and a key major success in Nigeria's case. So in terms of just growing MCPR, we can talk about growing MCPR, but in tangible terms, it has an impact in saving lives, in preventing unintended pregnancies, and avoiding unsafe abortions. Next slide, please. The other thing that we wanted to sort of note here is that in between 2013 and 2018, we saw a dramatic shift in terms of public sector family planning service delivery. In 2013, based on the 2013 NDHS, public sector family planning delivery was approximately 29%. By 2018, that had almost doubled to 54%. And more importantly, we saw this shift when we looked at the disaggregated number of users of key family planning methods. We saw that across injectables, across, and more importantly, across for implants. So we saw a large number of services being ramped up from the public sector side in terms of delivering FP provision. And that's really encouraging because it shows the hard work that the Federal Ministry of Health, that partners, state ministries of health, primary healthcare development agencies have put in to ensure that women have access to not only existing methods of family planning, but also in the new methods that are coming, particularly regarding implants. Now, it would behoove us now to consider the impact of the COVID-19 pandemic, because that's the reality that we're now living in. Despite all the progress we've made, we understand that this is a major challenge across the globe. And there's an expectation that it will impact contraceptive uptake and use, and that this impact might be a short-term impact or it might be a longer-term impact. And we're trying to look at it from two perspectives. One is from the supply side, and the other is from the demand side. On the supply side, where there are concerns around commodity, that's contraceptive commodity manufacturing, shipping, distribution, and issues around ensuring that the pipeline is able to reach the people that need family planning service in the due time. There's a concern around health, human resources in terms of focusing on monitoring and service provision, ensuring that they're able to do so safely. And there are concerns around the lockdown effect on movement of labor and community outreach and commodities access at the community level. And then ensuring that there's availability of acceptable alternative methods during this pandemic. From the demand side, obviously, there are concerns from clients around the fear of going to facilities and exposure to COVID-19. And as a result, clients may not have good information about provider and stock availability, and may not know, have a concern around when to be able to go to get a refill in the case that when they need to. Women especially face additional challenges with regards to having to provide with regards to out-of-pocket expenses to travel and to procure products that are not readily available at their regular sources of access. Next slide, please. So to address these challenges, the Federal Ministry of Health, state ministries of health, and state primary healthcare development agencies have been collaborating extensively, have taken leadership positions in terms of ensuring that there's, are you able to change the slide? The previous slide to this, please. Yeah. So in terms of that, we've seen that the response to the Federal Ministry of Health, working in collaboration with the Federal Primary Healthcare Development Agency, state ministries of health, and primary care development agencies at the state level, partners and community leaders to ensure compliance of all public health facilities with COVID-19 prevention guidelines. They've been great effort to continue and sustain family planning services through distribution of family planning commodities and additional support for community outreach. There have been strategic redistribution of health human resources for health across routine services, which includes FP. So they've been ensuring that that the services are available, that there are no delays to accessing contraceptives, and that there's safety in terms of accessing those family planning services. So these are important to understand within the context. And now, as I showed earlier, as how Nigeria has been progressing, while we may not have met our goal, we've seen that Nigeria has progressed pretty substantially when it comes to additional users and in terms of moving the ball forward on MCPR. But we anticipate there will be some impact on COVID-19. Nevertheless, we think that there's still opportunities given how Nigeria has waded through the COVID-19 challenges and is still up and running and still providing services. What we want to now do is talk about how, moving forward, we can look at possible opportunity gaps and take advantage of those opportunities in a way to ensure that we continue to grow in terms of MCPR. We continue to expand access to family planning, and more importantly, we continue to save lives by these initiatives within family planning. And my colleague, Suleiman Badamusi, is going to be talking about that from this point. Thank you.
Thank you, Dr. Adebiyi Adesina. Please, can we give him a round of applause, please? So I'm going to be looking at limitations in FP demand and opportunities for growth. The question we want to ask at this junction is this: what is really limiting our demand for family planning in Nigeria? We've heard, say, over the years we've been growing at the average of 0.4% averagely on a yearly basis. But across the 69 countries that Track 20 is monitoring, the average growth rate is 1%. So why is it that, although we are making progress, but why is it that we are not at our level? So to answer that question, we look at the demand curve. The demand curve shows the correlation between MCPR growth and the desired number of children that a woman wants to have. At the national level, based on the DHS 2018, the figure is 6, meaning average woman wants to have 6 children. What this means in terms of MCPR growth is that we can still grow our MCPR to about 16.5, which will show a growth from where we are presently, 12%, but we'll still be shy of the 27%, which we intend to achieve in 2023. We have also disaggregated this data so you can see what is going on in different geopolitical zones. You can see Northeast, the average woman in that area wants to have 8 children. Let's look at that figure closely. 1, 2, 3, 4, 5, 6, 7, 8. So do we now wonder why there's limitation to our demand for family planning in Nigeria? Right there is the answer to that question. So the focus of this is that we have opportunity of growing our MCPR, but there is need for demand generation. There's a need for stakeholders working in the demand generation space to get stakeholders, to get partners to reconsider the number of children that they want to have. Okay, I understand my time is almost up, but it's important that we make this point. So it's important that we re-strategize, and we need to be much more innovative going forward, all right? Demand generation is very, very essential moving forward if we want to increase our MCPR. That's the point we are trying to make. So in terms of opportunities, next slide, The opportunities are in two key areas: the demographics, youth and PPFP. Please, next slide. In terms of youth ages 15 to 24 represent about 40. Please, can you go to the next slide? The unmet need within this particular demographic is about 7%. For PPFP, the unmet need that we have in that particular demographic is about 15%. Next slide, please. In terms of absolute numbers, that youth, the unmet need, that 7% might seem vague. Okay. That 7% translates into about 3 million. These are people who are demanding to have family planning, but didn't have it for this year alone. If we look at PPFP, the unmet need, that 15% translates into 7 million. So these are people who are demanding to have family planning, but are not getting it. So these are low-hanging fruits that we need to retweak our programs to focus on youth and PPFP. Next slide, please. Now, the previous speaker mentioned something, that we've been able to grow our number of additional users by 70%. If we had focused on just 30% of youth and PPFP in this year alone, we will have been able to grow our number of additional users by more than 169%. 169%. That is the rate at which we will have been able to grow our number of additional users. So you can see that focusing on youth and PPFP is very, very important going forward. To round up the presentation, since my time is up, it's important, please next slide, it's important for us to focus on demand generation. We need to focus on accessibility and availability. We need to focus on expanding the access to different demographics. We also need to focus on strengthening the enabling environment. And more importantly, it's important for us to consider the local context of the states in which we are working. Thank you very much.
Please give him a good round of applause. Ladies and gentlemen, let me do some introductions so that we can be proper managed. First of all, let me introduce the Emir of Songhai, His Eminence Alhaji Dr. Yahya Abdullahi. I have a very good attachment. He was my senior house officer way back in 1980, Navy Teaching Hospital. So he was one that molded some of my experiences in life. Also, I want to bring the technical moderator for this conference. And he's no other person than Dr. Tunde Shegu, a public health physician of 30 years experience with extensive experience in reproductive health and particularly adolescent reproductive health. He was one-time neonatal focal person for ARH in the Ministry of Health and Deputy Country Director, JPIGO, and then also Country Director for A-Mandi, Mamaya Project. He is currently an independent consultant. Please welcome Tunde Shegu. To assist him, especially from tomorrow and even today, is another great gentleman, Mr. Stanley Chukwemeka Okerafo. He's an international multiple award-winning public and conference speaker. He is a creative media communication and development professional with over 2 decades of multi-industry, including SBCC. He is founder of Communicating for Impact, a public education, communication, and leadership skill development initiative. And he's also a consultant to reputable organizations, including development partners. Please welcome this fine gentleman. Tunde, I hand over to you. Thank you so much.
Thank you so much. We're running short of time, so we will quickly call on Dr. Fumi Olaolorun, who is an associate with Johns Hopkins University and also a consultant with PME 2020. Dr. Fumi Olaolorun will join us online. I don't know, can we have her online? And since we're running short of,
yeah.
Okay, great, you are there. So just before you go ahead, we will combine the remaining topics. So talking about eliciting despite at the state level and cross-section of policy frameworks. And I'm reliably also informed that Professor Adima will also stand in for Dr. Sama Anaskolo to take part of the discussions. Okay, Dr. Fumi Olaolorun, you have the floor. You have 10 minutes, please. Thank you.
Good morning, ladies and gentlemen. I stand on existing protocol, and I thank you very much for the opportunity to speak with you this morning. I'm representing Performance Monitoring for Action and would like to share with you about some of the state disparities that we have noticed in PMA data. Earlier on, Dr. Ejike said that when you see disaggregated data, then you're able to see the good, the bad, and the ugly. And I hope that a little of this will be shown in my presentation. For those of you who may not be as familiar with PMA data, I'd like to tell you a little bit about how PMA works. The survey is built around a resident enumerator, and the resident enumerator has a phone that has been pre-assigned to her. It's a mobile phone assisted survey. She collects data from households as well as from service delivery points. When she goes to the household, she speaks to the head of the household as well as eligible females in the household. And then when she goes to service delivery points, she goes to the private service delivery points within the enumeration area cluster she's been assigned. She collects the data using ODK and sends it to a central server where we have the data team regularly looking at the data for data checks for quality assurance. The data is aggregated and shared through data visualization means with end users such as you, so that you can know more about the data and use the data for informed decision making. By way of a background, the PMA survey is conducted in about 11 countries, and Nigeria is just one of them. It's currently being implemented by the Center for Research, Evaluation, Resources, and Development. We were formerly known as PMA 2020. We have support from the national level in Nigeria, as well as from the state ministries of health. We receive technical support both from the Bill and Melinda Gates Institute for Population and Reproductive Health, as well as from JAPIGO. And funding comes from the Bill and Melinda Gates Foundation. The main objective is to monitor family planning progress with a set of core indicators, and Dr. Adebi has already shared the core indicators, and I'll be looking into just about 4 or 5 of them today. PMA 2020 conducted annual surveys from 2014 to 2018. These were repeated cross-sectional surveys, and we collected data across 7 states with a total of 302 enumeration area clusters represented. The project, now known as PMA, is conducting data as I speak, actually. We just finished training yesterday for the Lagos team. We collected a round of data in 2019 / January 2020, and we're about going to the field from tomorrow. The Kano team has already started, and data will be collected for 3 consecutive years. This second phase of PMA uses a longitudinal design, even though we will have cross-sectional estimates. So we're currently working in only 2 states, Lagos, where we have 52 enumeration area clusters, and Kano, where we have 25 enumeration area clusters. So originally when we started only in Lagos and Kaduna because these were high priority states for the foundation. So we had the first 2 rounds there in 2014 and 2015. And then in 2016, 2017, and 2018, we added on 5 additional states: Rivers State, Anambra State, Nasarawa State, Kano State, and Taraba State. And you can see on the screen the total number of enumeration area clusters we worked in, as well as the number of women who were enrolled in the most recent survey round in 2018. So we had a total of 11,106 women in the most recent 7-state survey round. There are 3 main instruments for the survey: the household questionnaire, the female respondent questionnaire, and the service delivery point questionnaire. The service delivery point questionnaire is used for both private and public facilities. The resident enumerator, who is the interviewer, collects data from private service delivery points while her supervisor collects data from the public service delivery points that serve the particular enumeration area cluster. Now, with the new phase in PMA, we've added on client exit interviews, and these are largely conducted by supervisors because of the eligibility criteria, which I'll not be able to go into right now. Most of the wording for a large proportion of the questions related to family planning and reproductive health are from the demographic and health survey questions. So now I'd like to share some of the state trends, just a few selected indicators given our time. This slide shows current use of a modern contraceptive method by state in the PMA surveys in 2016, 2017, and 2018. The green bars are for 2016, the black bars for 2017, and the red bars for 2018. You can see here that modern contraceptive use is increasing in many of the states, in Lagos, in Nasarawa, in Anambra, in Taraba, and in Kano states. And the increase appears to be steady if you look at the trend, and we hope that we continue to see this steady increase. This next slide shows the proportion of women who reported using a long-acting permanent method by state, and this is married women. The previous slide was also with respect to married women. And again, the green bars represent data from 2016, the black bars from 2017, and the red bars from 2018. Long-acting method use is highest in Nasarawa, increasing from 7.7% in 2016 to 12.1% in the 2018 survey. But we can see that the trend appears to be increasing across states, with the exception of Lagos that looks like it may have plateaued. We hope to see an increase in the future. This next slide shows total unmet need for family planning by state. Again, among married women, the green bars are for 2016, the black bars for 2017, and the red bars for 2018. And the total unmet need is highest in Kano and then lowest in Anambra across all three surveys. In Kano, it's reducing from 38.2% in 2016 to 32.6% in the 2018 survey. And in Anambra, from 20.4% in the 2016 survey, unmet need has reduced to 13.4% in the 2018 survey. This is total unmet need. This next slide shows the percent of demand satisfied by a modern method, again among married women. And we can see here that demand satisfied by a modern method is highest in Nasarawa and Lagos states, both with over 40%, but it's lowest in Kano. And again, the trend within state appears to be similar across the three surveys. This slide shows the percent that reported that their last birth was unintended, and this is among all women. The previous slides had been with reference to married women. And again, this is for the same three survey years. The last birth was unintended in 36.5% of women in River State in 2016, 32.1% in 2018. But the highest for 2016 was actually in Kano with 45.2%. The highest for 2017 was in Taraba. And then the highest for 2018 was in River State. To sum up, family planning and reproductive health indicators as the snapshot of data I have shared with you shows. But state level data are very essential so that we can have actionable data for stakeholders. Disaggregating the data helps to be able to provide subnational estimates that can be used to actually make decisions and alter or change programs. PMA generates annual state level data that allows for evidence-based decision-making that policymakers can use, program managers can use, researchers can use, and even the general public. More funds should be budgeted and allocated for research by state governments in order to continually have access to actionable data for family planning and other reproductive health programs and services. Thank you for your kind attention, and please engage with PMA data as shown on your screen. Thank you.
Thank you so much, Dr. Fumi Olaolorun. Quickly, we have just about 10 minutes left, so I'll hand over to Professor Adima to moderate the remaining time we have left, so questions and answers and any form of discussions. Prof.
Thank you very much, Tunde. Let me congratulate all the speakers. Adebi Additional from the United States, Suleiman, of course, the last speaker. It's been a tremendous I'm on. Okay. Yeah, it's working, but it's not. Okay. Okay. Let us make use of what has been presented to us. You do appreciate how important data is to what we are doing. And we've had a beautiful exposition of where we are in terms of the availability of data. You can see the relationship between total fertility rate and contraceptive prevalence rate. TFR should be reducing as CPR rises. And we can see what is happening in the country, the disparities that occur by virtue of the various states of the country. But I believe that we are here. We are the people in the field, and we are supposed to make use of information available in order to achieve what we want to achieve in Nigeria, which is increasing our CPR and reducing our total fertility rate. So we throw the questions open to the floor, comments and questions. Let us make comments and ask questions. We have very little time left, but I believe we can clarify a few things with the time available to us and enrich this presentation, as it were. Questions? Okay. You introduce yourself and then.
Okay, Prof,
Yeah.
while they are writing
Right.
okay. While they are writing the question, Dr. Folabi, sir, can you make your presentation in 5 minutes?
Okay. Please write out your questions.
Thank you very much, Dr. Chidusegwu. We have the slides. I have a few slides there. I'll try to talk on the cross-section of policy framework, targeting major problematic challenges in Nigeria. We create an enabling environment to address this gap. So we have been given data of how poorly and how well a few sections of the country have been performing. What are these programmatic challenges? Well, I have to do this in 5 minutes, as far as much as possible, how to meet anything that is very important. Can we have the slides, please? So I tried to look at policy framework and break them into subgroups under the broader system, the micro input, service delivery, all this leading to output of improved enabling environment for reproductive health and family planning. Next slide, please. And the outcome for effective coverage of family planning and reproductive health services. Can you move the slide, please? The slides are not moving. I'm conscious of the fact that time is limited. I look at the National Health Act of 2014, and as you all recollect, this act was signed into law in October 2014 and provides a legal framework for the regulation, development, and management of Nigeria health system. The National Health Act has strong potential to transform our healthcare delivery through the Basic Healthcare Provision Fund, which of course is expanding access to primary healthcare to all Nigerians. So we see it as a strong tool to strengthen the health system as a roadmap to also achieving universal health coverage, as it provides for strong multi-sectoral collaboration for all healthcare workforce among the line ministry as well as state level governance. As we look at the National Health Policy of 2016, which is the policy to guide the federal, state, and local government to develop their appropriate strategic health development plan. And the vision of this policy is to ensure universal health coverage for all Nigerians, while the mission is to provide stakeholders in health with a comprehensive framework for harnessing all resources for health development towards achieving our vision of universal health coverage as is well encapsulated in the National Health Act of 2014. The goal of the policy is to strengthen Nigeria's system, particularly the primary health care level. And also, next slide, please. I also look at the National Strategic Health Development Plan 2018 to 2022. And I come down on the reproductive health priority areas of this strategic plan. There are a lot of priority areas across their system. I come down on the average priority areas, which include reducing maternal mortality and morbidity through the provision of timely, safe, appropriate, and effective healthcare services, promotion of demand and increased access to SRH and post-pregnancy care, as well as improving access to adolescent health and young people information and services. Also, one major priority is to strengthen prevention, treatment, and rehabilitation services for fistula care in the country. Is a neglected area, and also looks at reducing neonatal and childhood mortality and promote optimal growth, protection, and development of all newborn, as well as all the under 5 children. And I proceeded to look at the National Reproductive Health Policy, which will be due for review in 2021. This policy clearly emphasized in the agenda setting the need for effective and efficient reproductive health programming to advance the health and well-being of our population and for us to be able to harness demographic dividends. There are key priority areas of this reproductive health policy as well, ranging from early pregnancy and childbearing through early sexual development and sexuality, infection-free sex and reproduction, to achieving desired and intended fertility, including prevention of mistimed and unwanted pregnancies, right down through to achieving cancer-free reproductive life, gender equality, elimination of all forms of discrimination, and achieving reproductive health needs of persons in humanitarian settings. Finally, one major priority in this policy is achieving integrated reproductive health service along the continuum of care. The guiding principles are quite many. We have life cycle approach, universality, as well as right-based approach. It is country-led, adolescent-focused, It looks into equity around health, gender and age responsiveness, and it's also evidence-based. There are other guiding principles as listed there. And I quickly would like to talk on National Family Planning Blueprint, which we are all aware of. We are aware of the six, next slide please. We are aware of the six thematic pillars that address those issues and bottlenecks that came up during the landscaping between 2012 and 2014. And this includes demand generation, addressing the low demand and high unmet needs for modern family planning. Service delivery, addressing limited access to modern family planning methods, the supply chain, policy and environment, financing, supervision, monitoring, and coordination are the other pillar. We have revised this blueprint, and the new one is to be enforced between 2020 and 2024 to provide guidance for implementation of the activities across these key thematic pillars as listed here and as earlier mentioned. Next slide, please. Finally, before I drop the microphone, please permit me to talk on the accelerated reduction of maternal and newborn mortality in Nigeria. We have a roadmap for action between 2019 and 2021. This roadmap look at the problems at different levels, including political commitment, predictable disbursement of financial resources, and sustained unwavering focus on implementation, compounded by human resource challenges. Essentially, this roadmap was designed through a well-conducted situation analysis among 6 highest burden states in the country for maternal and newborn mortality, and 2 model states that have the best maternal mortality ratio we have recorded. And there are 9 recommended priority actions that this roadmap identifies, which if we follow, we'll be able to address most of the challenges we have around our MNCH and have improved health indices. This includes sustained political commitment, fiscal commitment to women's health, intersectoral actions to address social determinants of health, early timing and spacing of pregnancy, women's economic empowerment and financial inclusion, increased availability and quality of care, community engagement, strategic and meaningful partnership, all to be driven by quality data for decision making. And the key programmatic areas to be addressed include leadership and governance, policy and guideline health financing, capacity building of healthcare workers, quality of care, essential medicine, security, health information system, and community engagement. I want to thank you very much for the audience.
Okay, thank you very much, Dr. Folabi. Ladies and gentlemen, for want of time, we'll not be able to take questions directly, but put down your questions. They'll be taken care of at the appropriate time. And Tunde?
Yes, sir. Thank you so much. We have 3 questions. Unfortunately, we can't take them as Prof has said. We were hoping that those online would have been able to answer, but we'll put them in the chat room so that people can go there and view the answers. Just before we leave the hall and break out to and go to our parallel sessions, it's my pleasure to welcome on site, because I hear he's been online, our father and grandfather in the RMNC space, Professor Oladipo. You are most welcome, sir. Can you just say hello to us before we leave, sir?
Thank you very much, Shegun. Distinguished delegates, colleagues. This 6th conference of AFP is very, very timely. And I'm really delighted at the participation in person and virtual. It shows that we have come of age. And I want to commend Ejike Oji and all those who have supported him, our partners in particular, for making this a reality. Initially, we thought the conference might be difficult, but you can see that it is going very well. For me personally, as I listened to the young man from Washington, it gave us a ray of encouragement that despite not meeting our FP 2020 pledge of 27%, that we had achieved 70% of what we wanted to. And turning that round, you translated it into the number of lives saved, about 13,000 lives saved. If you translate that to the number of 737-300 series that crash, you see that is a great disaster for any nation. So I want to commend the effort of everybody in the family planning SRH landscape. We should not relent in our efforts. We should triple our efforts. And in concluding, the young man also said we should focus on demand generation. Really, in simple terms, it means we must produce programs that will change the mindset of both men and women, young and old, to develop family planning as a social norm. Family planning as a social norm. Our great-great-grandparents had it as a social norm. And what did they practice? Prolonged lactation and abstinence. 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 The sexual act is biologically driven, but it is man that moderates it. And we must moderate it. We have to do so. If we fail to moderate the population growth, this country will head for disaster. Government will not be able to meet the needs of everybody. We can see what is happening now. So many unemployed youths. But let us not relent in our efforts. The Interfaith Forum was here yesterday. And once again, they pledged their commitment. They will partner with Federal Ministry of Health. They will partner with NGOs. They will partner with donors and so on to ensure that family planning is part of the universal health coverage plan of the federal government of Nigeria. Once again, let me commend all of you for your effort, and we wish you well during these deliberations. Thank you.
Thank you so much, Professor Ladipo. Just before we go, I'm told that there are some snacks there. So before you leave this hall, for those who are not waiting for the parallel session here, kindly just take your snacks and you will be guided to the committee rooms. Let me say a big thank you to the panelists. I see Dr. Afolabi has left, but a big thank you to them. But just to also tell Prof, the current senior executive course 42 at NIPS just presented a report to the president on population growth and human capital development. And I can tell you that some of us influenced the fact that they had to put the family planning blueprint there. So it is in the report and recommendations to the president. So we are also attacking, and we can see some of the directing staff and the participants here from NIPS. So we are also attacking it at the highest level.